Good morning or good afternoon, depending where in the world you are. My name is Stefania Ilinka. I work as Technical Officer for Long-Term Care with the WHO Regional Office for Europe. And today we are very happy to have paired up with the Global Observatory for Long-Term Care and with the European Disability Forum, with the International Labour Organization, and with our partners, the Global Disability Fund, to propose to you a workshop rather than a webinar that marks the end of what we are very proud to call an ambitious project, but also marks the beginning of hopefully future collaborations with partners from the project and with many of you joining us today. So over the next 90 minutes or so, we hope you will bear with us as we give you an overview of some of the activities that we have been developing as part of the community-based mapping, community-based care resources for older people and with care needs and people with disability project. But we'll also move the discussion into a reflection phase. What have we learned and what can we take forward? And hopefully together with all of you, we can end the webinar and the workshop on a note that is future looking and ambitious looking forward. Where can we take this? What future pathways for collaborations do we have? And how do we accelerate accelerate progress, my apologies, on the deinstitutionalization agenda and strengthening community-based care in a global health environment that is increasingly more complex and under pressure. So let me very quickly introduce you to our speakers and panelists today. First and foremost, I want to thank Natalia Mattioli, who's program coordinator at the Global Disability Fund. Natalia has over 15 years of experience working with several UN agencies and governments on a series of topics and brings a lot of strategic project management expertise. Natalia will launch us in the discussion today. She represents, again, the Global Disability Fund. We also have with us today Hayden Hammersley, who's the Social Policy Coordinator at the European Disability Fund. Hayden is responsible for working on several aspects related to European cohesion policy, structural investment, the European Pillar of Social Rights, and he specializes in topics linked to deinstitutionalization and community-based care, social protection, and disability assessment. We have Özge Berger-Artaş, who's a gender equity specialist for the Decent Work team at the International Labour Organization. And we also have Padmaja Kankyapati, who is Technical Officer for Assisted Technologies at WHO's country office in Georgia. Now, I apologize to all speakers if I have mispronounced their names. They are going to be able to introduce themselves again when they speak. And without further ado, I'm going to pass the word first to Natalia Mattioli from the Global Disability Fund for a reflection on the fund's work on disability and deinstitutionalization and how they collaborate with international partners and with national partners. Natalia, the floor is yours.
Thank you. Thank you very much, Stefania, and welcome to all participants. I'm here on behalf of the Global Disability Fund. I am the program coordinator at the Global Disability Fund, and we are very proud to be here today and to be able to launch this very interesting discussion. As Stefania said, I will briefly provide an overview of what the fund does and specifically our investments around community care and support services and the institutionalization. So the fund was created in 2012. I suppose many of you know it with the name of the UN PRPD, UN Partnership on the Rights of Persons with Disabilities. And last year, we actually changed the name to Global Disability Fund, as it reflects also the expectations of our partners, our donors, in terms of the work and the reach of this funding mechanism. So this is really a funding mechanism that was created to support the Convention on the Rights of Persons with Disabilities. We operated through a pool fund. We are based in New York and hosted by UNDP. And we operate both at the global regional and country level, mainly country level. So I would say 80% of our investments go at country level. We do also have initiatives, as the one colleagues will present further today, that involve more than one country. So we define them as multi-country programs, which have a specific focus on developing knowledge tools that can be then applied to different contexts and different countries. Our programs are designed in a very similar way, independent of the type of programs that it is, so multi-country or country level program. We bring together the UN system, so at least one or two UN agencies, civil society organizations, so organizations of persons with disabilities, and the government. So we come together, bringing together the different expertise. At the core, we do have persons with disabilities and ensure that they participate throughout the program and are involved in the design and in the implementation of the program. So to date, we do have implemented over 100 programs in, I think, over 120 countries, and we have invested over $100 million. Our programs are not, with a limited budget envelope of around between 300,000 to 700,000. But in the last years, we have seen an increment on the work around community care and support systems. Our focus of intervention spans from access to health, access to education, access to justice, employment. Usually what we do at country level to identify what are the priority areas for work is we carry out a situational analysis, and together with the government, with the Organization of Persons with Disabilities and the UN system, we define the priorities at country level, and based on that, we design the programs. As mentioned, the last situational analysis and also a global interactions with key actors around disability inclusions has brought us to increase the work on the institutionalization specifically and care and support system. We do have 3 active programs. This is actually closing the one that we're here for today, implemented by WHO, ILO, and the European Disability Forum. We have another program that looks at budgeting specifically, which involves UNICEF and OHCHR. And then we have a larger program that is part of also an earmarked investment from one of our donors on unpaid care and support systems. So this, as mentioned, is one of our key topics of investment at the moment, and we are launching the new strategy that will be published in September 2025. And the new strategy would look at a holistic approach to disability inclusion, and care and support system is one of the cross-cutting topics of the thematic areas of work that we will look at. So we definitely think that this program and this guidance note that will be discussed today is timely, also to look at where in the future strategic investments are needed to advance the discussion around the institutionalization and care and support systems. So we look forward to the discussion and to participate in the discussion. And thank you again to all the partners that have implemented the programs. Thank you very much.
Natalia, thank you so much for that broad overview. It was fantastic. And as you were speaking, I was looking through the participant list as well. And I take this opportunity to, first of all, thank you for taking a chance on this proposal. because as you said, indeed, it is grounded in a focus on deinstitutionalization and improving community-based care for people with disabilities. But you have been so open to discussing this agenda also in the context of population aging and understanding that while there are separate traditions and separate maybe historical developments in the long-term care for older people policy agenda and the supports for people with disability agenda, many of our core principles and our vision for what future care should look like and support services should look like are shared. And in fact, we have grounded this entire work in a focus on deinstitutionalization, but also prevention of institutionalization, making sure that we go towards a future where, irrespective of age, anyone who has and who can care and support needs or who can benefit from care and support services has access to them, so that institutions become as irrelevant as possible. So thank you very much for that, and I think that is a good segue into giving the floor to our next speaker, Hayden. Please pick up from here and do introduce yourself if there is something that I have missed in your introduction. Hayden represents today the European Disability Forum. Please, the floor is yours.
Thank you very much, and it's a pleasure to be with you today. So my name is Hayden Hammersley. I'm the Social Policy Coordinator at the European Disability Forum, and we were very happy to be involved in this project from the get-go. We were helped very much in our country visits to Georgia and Armenia by our members there, so notably the Disability Rights Agenda NGO in Armenia and the Coalition for Independent Living in Georgia. So it was extremely interesting for us to see the differences in these two countries compared to what we know within the member states of the European Union, to see where we are at different phases of the process, moving away from dependence on institutions towards independent living and inclusion in the community for persons with disabilities. So I'm just going to share my screen because I have a short presentation to share you, and what I aim to do as we continue this session, to go back, is to explain a little bit what our position on deinstitutionalization is at the European Disability Forum, to give a little bit of context about where the countries of the European Union are in their transition away from institutions and how this compares a little bit, therefore, to the countries we've focused on in this particular project. And also to see internally what we're advocating for as investment priorities and solutions for what we see as the overdependence that remains on institutions in Europe. So just a bit of context on the on institutionalized persons with disabilities in the European Union at the moment. A report was released in 2020 that showed more or less 1.5 million persons with disabilities still living in institutional settings. And this figure is just an estimation, because actually one of the main issues we face in Europe, as is the case in many parts of the world, is the data collection that we have on persons living in institutions. So while we have this figure of 1.5 million, more or less, we know that there are many people who are simply left out of the data collection process and are therefore not counted. So it could be indeed much more. Another issue is that despite the ratification of the UN Convention on the Rights of Persons with Disabilities and the focus that this clearly has on moving away from a dependence on institutions, in the European Union, at least, we haven't seen any significant improvement in terms of reduction of number of persons with disabilities in institutions over the last 10 years. There was actually quite a damning report that was released by Eurofound last year, which showed that 13 of the 27 EU member states not only hadn't made any progress in supporting persons with disabilities out of institutions, but had actually increased the number of persons with disabilities in institutions. I have here a list of countries. Some of them have very slight increases, and some have quite significant increases. So we have countries such as Denmark, Croatia, Luxembourg, Ireland, Latvia, Malta, the Netherlands, Poland, Portugal, Sweden, Slovenia, Slovakia, and France. And if we take the example of France, for example, the increase over the last decade was more than 100%. So they are now more than twice as many people in institutions or persons with disabilities in institutions as there were 10 years ago. And one of the things we also need to clarify is what an institution is, and therefore what these studies were referring to when they were talking about the number of people in these countries in institutions. So we as the European Disability Forum follow very much what's prescribed in the CRPD, so the Convention on the Rights of Persons with Disabilities, and also in the General Comment 5, which elaborates on the Convention and its Article 19. So in this setting, whenever we're referring to institutions, at least as the Disability Forum, we refer to residential settings that show isolation or segregation from the community, where there is no or limited influence over whom a person has to accept their assistance from, where there's lack of control over day-to-day decisions, which can be any number of things, but it could be anything as simple as what time to get up, what a person wants to eat, who they spend their free time with, what they do in their free time, a lack of choice over whom to live with, which is one of the things that's clarified very specifically in the UN Convention. Not being able to decide freely when to visit friends or family, or having this decision taken by someone else. Facing restrictions again over if and when you can have guests that come to visit you. And then in general, we see in institutions rigid routines that don't take into perspective personal will or preferences, and a general imposing of group activities under the authority of the service providers. So when we're talking about institutions, in our case, this is what we're referring to. So what I mentioned before in itself, we see as a violation of basic human rights and the rights that are enshrined under the UN Convention on the Rights of Persons with Disabilities. But it is also important to remember that the human rights issues that we see in institutions aren't just limited to this, and we do sometimes and too often observe more severe human rights violations. In our position paper as EDF that we released relatively recently, we outline some of the more publicized cases of these extreme human rights violations, but I'll just say here that these are cases that we show of severe abuses, violence, sexual assault, and even forced sterilization in some countries. The ones we expose in our position paper were the ones that got media attention, but for every case that gets media attention, there are, of course, many that remain hidden and simply are unreported on. And then, of course, when it comes to children in institutions, the lack of support for their development can mean that they're more likely to be left outside of education and to be able to live independently later on. So I know I don't have much time left. I will go over just a few of the many recommendations we have, because otherwise this will take a long time. But I will start with this one, which is important because it's already been mentioned, which is on preventative action. It's always important, if possible, to prevent people being placed in institutions before it happens, so to act ahead of time. We advocate for a number of things, and I can share these slides afterwards, but important initiatives are, for example, financial support that goes towards informal carers. So if a family or any informal carer and the person with disability both agree that this is the best option, then the provision of support should be reimbursed and should be compensated to make sure that people aren't risking poverty and social exclusion by way of offering support. And it's most often women that take on these roles and who suffer as such. But in general, in-home support is also very important so that people can get the support they need where they're living rather than having to move and therefore ending up in institutions quite often. And also, of course, support in finding employment and managing finances for adults with disabilities, this is, of course, a type of support that really increases the chances of being able to live as independently as possible. Mm. And then I will finish on this one, and I will again share the slides as I mentioned before, but when people are already living in institutions, it's very important to offer the right support and to do so very carefully when people are transitioning away. So all of the options for what exists outside of institutions needs to be made very clear. It needs to be presented in really understandable terms, and the consequences of the choices of leaving an institution need to be made quite clear so people can express their preferences. It's important also to accompany resident or former residents of institutions as they make this transition, so that the move into what can be a completely new way of life, faced with lots of choices and lots of freedom, be done in a supportive environment, and that people aren't just thrown out to discover it for themselves. On top of this, it can be important to rebuild links with families and friends. That can often be a reason that people end up in institutions, particularly those with mental health issues that might have broken relationships with their support network in the community. And of course, many people will leave with psychological and physical trauma that they will need to have support addressing in order to be able to move forward and continue their lives living independently in the community. So in order to give us time for a discussion, I will stop there and I'll hand back to Stefania. So I'll stop sharing my screen and hand back to you. Thank you very much.
Thank you so much, Hayden. No, that was fantastic. Thank you for taking the time to set the background on this. Colleagues are asking for the slides, so we will take you up on that offer. And to balance everything you said, I come from a long-term care background, and I've always worked on long-term care, but everything you said from the disability perspective, other than mentioning age and how age features in some of the statistics that you've presented, resonated perfectly with me. But in keeping with this balance between the long-term care for older people and disability support, I want to pass the floor very quickly to Adelina Comas Herrera, who is a very accomplished researcher in the field with, I don't know how many years of experience, Adelina, I'm not going to guess, but she's also the director of the Global Observatory for Long-Term Care, who is hosting us today and who has made this workshop possible. So Adelina, I'm wondering if you can reflect briefly on Hayden's presentation and how the prevention of institutionalization and deinstitutionalization are reflected as concepts and as policy priorities in the long-term care for older people agenda. Please, the floor is yours.
Yeah, thank you so much, Stefania. And we're absolutely delighted to be hosting this webinar today. And I think this is a hugely important topic. Just let me say that when we talk about I direct the Global Observatory of Long-Term Care, and in the definition that we use, we include people who need care over the long term of any age. So we are very happy to include all ages and all reasons for needing care as well. The observatory grew out of an initiative called LTC COVID, where we basically came together as a group of researchers that kind of knew each other and started to collaborate and share information about what was happening in the pandemic, particularly in institutions, in care homes, and trying to, first of all, make sure that all countries were taking the actions that were even available to them, because not all of them were prioritizing people living in these settings, and we knew they were a very high risk. And there were also very clear violations of human rights or additional violations of human rights in terms of separating people from families longer than it was absolutely necessary, and all sorts of lessons as well, I think, about just how we need to build I'm going to call them congregate settings in the future, if that is a form of care that is available. I think this is a really important discussion to have. I really appreciated the description of what's an institution from Hayden. I think that we need to be really careful with our language and understand as well that for some people, congregate living with others may be a choice and maybe something they decide to do. And now we're seeing cooperatives of co-housing emerging in many countries, and it's very interesting to see the difference when these are settings that are created by the people who are going to live there and who are going to live there according to their own rules, compared to when all of this is imposed on them. In the long-term care area, we have a long way to go. We definitely don't have the necessary, in most countries, infrastructure to ensure that people can continue to live in their own homes, in their own communities if they wish to. Many people are being forced to move into institutions because maybe they live on a third floor without a lift. And we really have a long way to go in practice. We, as an observatory, like to bring people together and have discussions. Like at today's webinar, we like to share the excellent work and tools that so many of you are working on. My colleague Naz, who runs the observatory with me, is going to put a link to the observatory, and also you can join for free, and then you get emails and invitations to even more webinars. But we also share resources and tools. So we will be sharing the slides from today if the speakers wish to, as well as any tools that you share with us. So with that, I'd just like to welcome you all. Thank you for inviting us to be part of this, and looking forward to learning more about this work.
Thank you so much. Thank you, Adelina. Indeed, I do tend to agree with you, and I'm willing to even be quoted on this. I think in the long-term care sector, we need to take inspiration from the disability support movement and how much and how quickly it was achieved with a lot of effort and a lot of work. But I think it's something that we can replicate here. And as you say, in WHO's definition of long-term care, we also don't propose any age distinctions. Long-term care is for anyone who needs it, anyone who experiences functional limitation and can benefit from such services and supports. In practice, however, we do see that policies have age cutoffs, and eligibility to many public programs are determined by age and by maybe the specific disease or pathology that is causing care needs. And this is something that we need to overcome in practice. So without further ado, I'm going to share my screen and give you a very quick overview of the work we have been trying to do in exactly this spirit. The challenge that we took on with the support of the Global Disability Fund was to look at how we can map, how we can define, and how we can map community-based care and support services for people with disabilities and for older adults with care needs, in the understanding that deinstitutionalization agenda has to be grounded in strong community-based care. The goal is not just to not have people in institutions, but to make sure that people don't need institutions because they can get the care and support they need in their homes and in their communities. So in order to not put the carriage before the horse, first and foremost, we need to start by investing in strong community-based care and support services. And then we can try to shift the weight of the system from facility-based care, from institutions towards the community. As I have mentioned a few times, the project that we are presenting today and that we are concluding after 22 months has been delivered by WHO Europe and the ILO Office for Eastern Europe and Central Asia, with the generous financial support of the Global Disability Fund and in close collaboration with the European Disability Forum. We have looked at how we can support the institutionalization through strengthening community-based care and support services, and have focused our resources on developing technical support tools, primarily a technical toolkit and an implementation guide for identifying and mapping community-based care and support services, and the workforce that delivers them. So you might have wondered, until now, we have mentioned the ILO quite a few times, but kept talking about service development. Well, a very important part of what this project proposes is that there is no care without caregivers. And to talk about care and support services without interrogating who is delivering these care and support services, under what conditions, at what level of quality, and with what training, would be, again, could be misleading and could be less than productive. So the partnership at WHO and ILO has come as a reflection of a belief that we need to progress on policy for service development and design hand in hand with improving policy and working conditions for the workforce that delivers these services, but also for those caregivers who may not have who may not deliver care within the limits of a formal employment contract. So recognizing the diversity of services, but also the diversity of the caregiving roles that are associated with it. The goal of the technical tools we have developed is truly global. We have developed it looking primarily at the European context, and we understand that this carries some limitations to it, but we believe strongly that the topics we have addressed and much of the issues that we map in the toolkit have truly global relevance, although of course some adaptation will be required depending on the setting this is applied in. At the same time, we've tried to develop the toolkit from an evidence-based perspective and an expert-led perspective, but very closely informed by practice. So as we were developing the technical side, we were working at the same time with organizations on the ground, including organizations of people with disabilities and local governments and local service providers, to apply these ideas in practice and to see to what extent they need to be adjusted, modified, simplified, so that they are relevant for practical implementation and can really guide policy decisions and design decisions in a real life situation and at service delivery level. So what we have produced over the last 2 years are the main report, which is Mapping Community-Based Care and Support for People with Disabilities and Older Adults with Care Needs. This is the flagship publication, and in an annex and a guide to implementation. The goal of producing a guide for implementation is, of course, as Natalia has mentioned in her opening remarks, that our ambition is that these tools are relevant for national and regional stakeholders, that once produced, they can be taken up and be adapted and be useful in policymaking and service design and organizations at all levels. So we hope that we have managed with the implementation guide to step one step further towards practical applicability from the more abstract and high-level policy-oriented overview of services and the workforce delivering them to the guide to how this structure can be used for practical evidence-based policymaking. And of course, we are happy to provide further information and to answer questions or clarify how the toolkit was developed and how it was implemented. And country teams will do the same a bit later today. At the very core of the framework we are proposing, and I think a lot of the keywords you have already heard today, is the understanding that there are 3 crucial areas of services that need to be available in the community and at a high level of quality, of acceptability for the users of such services, to allow them to remain in the community while maintaining quality of life and level of dignity and autonomy that is consistent with their human rights. First and foremost, direct care and support services, which we differentiate within our framework across 6 domains, which will probably be recognizable to many of you from the WHO DAS assessment. But these are mostly centered around issues linked to need for support with mobility, with cognition and mental health, with personal care, with social connection, with life activities, and with community participation. Altogether, 6 large domains of care and support needs that need to be addressed by direct care and support services in the community. A second very important component is disability and age-inclusive healthcare. As Hayden has already highlighted, and as Adelina was also hinted at, we don't only need dedicated care and support services, but we need all mainstream health and care services to be accessible for people with disabilities and for older people with care needs. And finally, but equally important, we need support for informal community-based care resources. It remains the case that it is mostly our families and our communities who deliver the vast majority of care and support. And within a policy agenda that emphasizes community-based care, we need to invest in these informal resources rather than expect they will always be available at the level that is needed. The outer shell of the framework highlights 6 key facilitators that are required, that are necessary for these 3 main components of care services to work smoothly and to be delivered effectively and at a high level of quality. I will not go in much detail, but of course, it is all rooted and grounded in an optimized and competent workforce. And Özge will talk a little bit more about the workforce perspective. Equally, I think you will recognize in the way we have described the services in the community that are considered in the toolkit, that they span sectors, they span the health, social protection, welfare, housing, education sectors, and many, many others. There's a need for quality management, and this again reminds me of Hayden's presentation and how he described aspects of what are non-desirable characteristics of care services. Everything in the community is grounded in the environment, so we need inclusive public spaces, but also inclusive and accessible private spaces and home spaces, so adapted housing. And finally, facing a situation of increased demand while both human and financial resources are limited and already showing shortages, we need to leverage digital technologies in a way that enhances compassion and empathy and human touch, not in a way that replaces it. What is the structure of the mapping? Taking it one step closer to practice from the large domains to the actual mapping and implementation of services. For each key domain that I have presented in the core structure of the framework, we have tried to further break it down to the specific types of services, interventions, and programs that are most likely to be observed in practice as most likely to be useful and effective. Now, the list in the diagram we are showing here on the right is only partial. I invite you to consult the publication for an even longer, more comprehensive list, which in itself does not aim to be fully comprehensive. This is impossible, but hopefully we have given sufficient background and sufficient inspiration and sufficient example to understand the diversity of the types of interventions and programs that would be required to really respond to the complexity of needs that we see in practice. Furthermore, moving even further to the right within our diagram, for each broad category of services, interventions, and programs, we have also tried to map who are the key professional profiles and caregiver profiles, I should say, that are essential for the delivery of those types of care and support services. And I do want to walk a little bit back my use of the word professional, because as you see in the list, we actually also map the role of informal caregivers who, by definition, deliver this type of support outside the remits of formal employment contracts. What is important for us to highlight with this mapping between services and workforce is that it is essential to have the right training and the right qualifications and the right skills and competence in the workforce to deliver the types of services that are required. So you will see in the mapping of professional roles quite specific types of care professionals that do not exist or are not trained in sufficient numbers in many European countries. So this helps in the mapping, in that we can map what services there are, what capacity these services might have with the workforce that delivers them, and to try to understand if we come anywhere close to matching the size of the demand with the size of the supply, but also if we are close to providing services at a level of quality and professionalism that would be ideal. So in the implementation guide, we provide a template that is a recommended template for how such assessment could happen by trying to look at what service program exists in practice, categorizing them according to the framework, trying to define what their capacity is, but also what are the human resources that are delivering such services. So then by reproducing this type of mapping for all services that exist in practice, one can then almost map them over the overview of the framework that I have presented before and identify where service gaps might exist, where human resources gaps might exist, where entire areas of need might be insufficiently covered, or where all areas might be covered, but not at a level of complexity that necessarily reflects the needs in the population. So I will stop here. Thank you. We'll put all the links to the publications that we have presented in the chat, but I want to end on the thank you message to all of you for listening to us, but also to our many partners. And I want to very quickly acknowledge that this publication has been developed with the help of truly numerous experts across Europe, but I am particularly grateful to our technical advisory group. Cassandra Simmons, who's joining us on the call, has been coordinating the publication development with me, but we are also very grateful to Leo Gupil-Barbier and Natalia from the Global Disability Fund, to Gian Matteo Apuzzo from the European Center for Primary Healthcare, to Dorica Dan from Eurordis, the rare disease umbrella organization for Europe, to Hayden Hammersley, to Carrie Hand from the University of Western Ontario, to Professor Elizabeth Hansen at Linnaeus University, to Moshe Hovsepian at the Disability Rights Agenda in Armenia, and to Philip Seidel at Age Platform Europe, who have truly been co-authors and have accompanied us through the development of these publications. So with that word, I will pass very quickly to Ozge, as I am realizing I took more time than we had planned and we are a little bit behind schedule, but I want to make sure that Ozge also has an opportunity to describe the work from the perspective of the International Labour Organization.
Yes, Stefania, thank you so much. So, dear colleagues, good morning, good afternoon. I will try to not to take much of your time, but let me first introduce myself. This is Özge Berberataş. I'm the Gender Equality Specialist of the ILO Sub-Regional Office covering Eastern Europe and Central Asia. And it's such a great pleasure to be part of this implementation of this such a very innovative and unique, let's say, project together with the WHO colleagues, together with Stefania and colleagues based in Armenia and Georgia as well. So from the ILO's perspective, let me just, very briefly about the ILO International Labour Organization is just, established in 1919, almost more than 100 years ago, with the aim of setting the standards at the global level on promoting social justice and decent work agenda for all workers, regardless of their contractual status, formal or informal, and everywhere in the world of work. And we are the institute, we are the organization, UN organization, setting the standards, global standards, conventions for the countries with the tripartite setting, together with the workers' organizations, employers, and the government institutions. Why I am telling this? Because the role of our role in this project implementation was to understand the working conditions and also working conditions of the care workers, both in Armenia and Georgia as well. Hayden mentioned about the importance of human rights aspect, and also Stefania mentioned about the informality in the care sector as well. So all those really keywords, in fact, reflects the importance of the promoting decent work agenda across the world and protecting the rights of care workers. Because what we know, based on the discussions and based on the reports and the also analysis we did in Armenia and Georgia, is that if we don't ensure decent work conditions and satisfactions and the well-being of care workers, we won't be able to get really qualified care services provided to people with disabilities. So that is very important to have such, building such linkages between the working conditions and the quality services, care services provided to people with disabilities. So as an ILO, what we did in both in Georgia and in Armenia, we conducted field research and analysis, analyzing the working conditions of care workers providing services to people with disabilities. Particularly in Armenia, we have collaborated with the Disability Rights Agenda, and in Georgia, we're also collaborating with also different institutions, and also we are collaborating with the government and the workers and employers organizations. And the second analysis we are also working as an ILO, both in Georgia and Armenia, is the review of financing and budgeting for care-based services. So this is all about how much the governments are investing in the care system in those countries. So just to analyze what is the importance of financing, public financing in those countries as well. And looking into the working conditions of analysis, I just would like to say a couple of words also what we are looking and what we would like to see in fact. So in our analysis, both in Armenia and in Georgia as well, we looked into the employment structures and also including the contracts and benefits of care workers, providing care services in the public institutions and also in different community-based care institutions and the services as well. And we also looked into the skills development and education and training, and Stephanie already mentioned about the importance of the skills development of care providers as well. This is also very much relevant to not only for the formal care workers, but the informal care workers as well. And when we look into the working conditions, we also look into the working hours, shift patterns, breaks, and also the leave rights and the maternity rights and paternity rights as well. Safety at work, health at work, and also the violence and harassment practices in the workplaces is also another concern that we looked into in our reports as well. Remuneration, equal payment for work of equal value is also a very important concern for all of us. And last but not least is the voice and participation of workers under the trade unions. So how those care workers have the right and opportunity to represent themselves in the associations and in the trade unions to be able to bargain collectively with the government to regularize and to improve their working conditions. So these are the key elements, that we have looked into in our reports when we are analyzing the working conditions. Just a couple of words, maybe, from the analysis, particularly from Armenia, but also from Georgia as well, that, what we see is that, the findings definitely shows that the clear relationship between the, working conditions, job satisfaction, workers' well-being, and also the quality of care and client satisfaction. So, but unfortunately, this relation is not really straightforward for many countries. But sometimes it is really seen as an abstract addition. But what we know is that, for example, for Armenia, what we see is that the care of workers suffers a lot when it comes to the safety in their work, when it comes to the violence and harassment practices, and this also impacts on their mental health, which also indirectly and at some point directly will impact on the also mental health of the service receivers as well. So, and also the care workers in Armenia, they also have limited opportunities to organize under trade unions. They have very limited time available for their personal well-being, for their personal development, and they're also very much suffered in terms of long hours, working long hours, which increases their stress, and also they suffer also unbalanced shifts as well between the night shifts and the daily shifts as well between different colleagues. And they see that, this is a very tough job, and they think that their work and their value, their added value to the society is not well respected and well appreciated. And this is the sector, we should not forget that this is the sector that is really dominated by the female workers. And also, when we talk about the community-based services, we also mention about informality. Now, the governments are moving and shifting towards from institutionalization to the more community-based community level solutions, which is very important for the independence of the work people with disabilities, as Hayden already mentioned. But what is really important that we should not forget, that when we push and move towards the community-based solutions, then we will start working with individual care workers, mostly domestic workers. And they are mostly working informally without any social and labor protection. And they don't have any contractual relations, and they don't have the necessary skills also as well to provide the necessary and quality, let's say, services. And they are also working with very low wages and long hours without any concrete, let's say, terms of references in terms of what jobs expected from them as well. And this definitely leads to decrease in the quality of services as well. So these are the key elements that we would like to advocate and promote in those countries, in both countries, with the government and workers and employers, so that the care workers are fully respected and their voice are fully heard by the respective institutions and the ministries as well, and the employers as well, so that we will have a good dialogue between the workers and employers and the government institutions as well. And on the other hand, we would like to also better understand what is the investment level of the government in terms of, in terms of care services, provision of care services to people with disabilities, and what is the trend in terms of, receiving those services from the people with disabilities and the perception of people with disabilities. So we have conducted several interviews with the care workers. We have engaged with the OPDs. We have engaged with the persons with disabilities as service users as well. We just wanted to understand also their perceptions as well. And also we wanted to document their experience and also challenges faced, not by only the care workers, but also people with disabilities in terms of the quality services and the availability of services in both countries as well. So we have also just final notes that Armenia has ratified some of the key conventions, ILO conventions like equal remuneration, and also ILO Convention on Discrimination. And discrimination is the key convention for us also for providing decent working conditions and also good services, quality services for people with disabilities as well. And we have analyzed the legislative framework and current legislation and laws and policies, whether they are aligned with the ILO conventions or not. So, and we have come up some policy recommendations for further improvements in the legislation, but not only in the legislation, also in the practice, in the implementation as well. So I think this is a very good starting point, entry point for all of us to rethink about the linkages between the care services and the rights of care workers. And we do hope that we will continue working in this field in different occasions. So I think I should stop in here, just, mindful about the time. So over to you, Stefania. Thank you.
Thank you so much, Özge. I'm not going to reflect on that because I want to make sure that I also give Padmaja a few minutes to reflect on everything that we have said from the international perspective and how the project has unfolded at national level, and maybe, some of the lessons, experiences there. And Padmaja will be talking about the experience of Georgia. And right after, we will be moving straight in the breakout rooms to give you a chance to jump in the conversation. Apologies for taking a bit longer than we had planned, but I hope you agree this sets a good background for the discussions. Padmaja.
Thank you so much. Hello, everybody. And I think this, of course, like Stefania mentioned, it's a lovely backdrop to what unfolded in Georgia and what we've learned along the way. To give you a bit of a country context, the social services are highly decentralized in Georgia and very fragmented in the way of the nature of the services. However, I can give you a kind of brief in terms of some of the key services that are offered from the Ministry Department of Social Services. We have a variety of daycare centers that promote independent living and social integration for persons with disability. We have programs that the ministry supports for the provision of assisted products. There is a national priority list of products that they adhere to, out of which I think there are 30 products and 19 are funded, state funded. Additionally, the rehabilitation services, a few are funded through the state universal healthcare program, specifically for stroke, traumatic brain injury, and spinal cord injury. Additionally, there are two key programs that the ministry has undertaken in the past year or two, which is the home care services that provide support to individuals in their homes, that promotes independence and prevents institutionalization and supports the families. Additionally, the personal assistance services are offered to support independent living for persons with disability. And just to give you a brief idea in terms of how organizations of persons with disabilities are involved, one of the direct roles in terms of delivering the services is through their independent living centers. And these independent living centers are quite active and they provide a lot of support and information, consultative services. They're spread across the regions in Georgia, and they're doing very well in terms of really supporting community participation. What we have found and learned through our stakeholder consultations, where we presented the findings, there is a certain aspect of mental health that needs to be more strongly integrated into these services offered and represented as well. Additionally, regarding older people, I think one of the specific issues that they are finding, and the ministry, of course, is actively aware of the situation and they're working towards it, is to understand the transition in terms of older adults availing of these services requiring a disability determination status. So this is an area that was keenly highlighted during the consultations, and the ministry we just had our final consultation yesterday with stakeholders where we presented the findings, and the ministry provided an overview in terms of how they're going forward to improve the services and really try and work on the implementation of these programs, which many of the stakeholders viewed as kind of theoretically, these programs are available, but implementation has to be followed more strongly. Monitoring mechanisms need to be in place, and the ministry, come this September, they're going to do an entire assessment of all the services that they're offering through their social health programs. So I think this report was very good, and this work was very good in bringing the highlight on the discussions needed and the dialogues needed between the stakeholder and the ministry. And it's provided a lot of guidance and areas that need to be worked on. So I thank Stefania and Cassandra in particular for their guidance and support. It was definitely a challenging project to get everyone's views and opinions reflected accurately in the report. But we appreciate all the support, and I'll stop there because I know we are short on time. But if there are any further questions, please do let me know and contact us.
No, thank you, Padmaja. That was perfect. In fact, I think you've set us up perfectly for the discussion. It has been challenging. It's easier said than done, and this is exactly why we are here in this workshop today, counting on everyone who's joining us in the audience to share their knowledge, their experience, and their ideas for how we can do this bigger and better from here on. So Adelina, I give the word to you to explain how we switch to the breakout rooms.
Yeah, thank you. So now with my colleague Naz, we're going to send you to 3 breakout rooms, and there'll be a moderator in each room. We will have some questions for you. So if you want to start thinking about any ongoing initiatives, projects on the institutionalization in your countries or that your organizations are involved in on the prevention of the institutionalization as well. And we want to think also about how to bring together better collaboration between the disability and the older care sectors. We also want to know about interesting partnerships, collaborations you may want to mention, especially to support local implementation, and whether this is available to people of all ages or only younger or older people. And we want to know what are good approaches to bring people together and to make change happen and bring together the different levels. So with that, we're going to move you. I think Naz is in charge of that, and I'll see you soon.
So unfortunately, we had planned to feedback to the group very briefly. I'm not quite sure we will have time to do that, but if the moderators would be willing to share maybe the 1 or 2 big ideas that stuck with them, we can do that in the next 5 minutes or so, and then we'll pass it on to you for the satisfaction survey and final feedback. I think from our breakout room, a few things really struck me. I'm happy that what we talked about resonated with people from different continents, although there was also clear scope for adaptation and interpreting in context some of the ideas. I think the issue of how informal care and informal care resources are recognized and supported is truly a global challenge, and that we have a lot of scope for exchanging more learning and experience there. And I hope that today is just the first step. We haven't really discussed about networks and where these networks might go and how they might be created, but I think there was quite a bit of interest of linking across long-term care and disability support, as a few people in our room clearly have worked their career across this maybe artificial divide in policy. Breakout room 2, who wants to?
Yeah, that's the group I was in, and we had a very nice conversation. We learned about the experience from Malta to actually support people who are in care homes to move out into the community, and the importance of supporting people and have a personalized model for them. We also heard about in Ireland the housing with support initiatives, and how this is based on universal design. People have their own rooms, their own front doors as well, and the potential there would be if some of the funding that's already taking up a lot of the budget from residential care was able to use to support these schemes. From the Netherlands, we heard about these new residential mixes that bring together people with disabilities, people without disabilities, different ages, living together. And the great thing about it is that there is support from the Ministry of Housing and quite a bit of investment to support it. And from Brazil, we heard that they're at the early stages of thinking about a national care policy. They're learning from the experiences of Uruguay and Chile. And we heard also that the academic gerontologist communities are working hard to also improve the use of language to make sure it's not the stigmatizing, which all contributes to, of course, this othering of people and institutionalized approaches. And the importance came up across of having a good collaboration with housing ministries and the challenges that in some countries very high housing costs pose to this type of schemes. So that's our group. I hope I summarized well.
I'm glad we're recording this because I have not been able to take notes in parallel. Cassandra?
Yeah, so we had a great discussion. I found there was quite a global group in our breakout group number 3. So I'll just highlight 3 major points that stood out in our discussion. So the first point was just this recognition that this is a universal challenge, bridging this disconnect and this fragmentation between disability sector and long-term care sector, although countries have been trying to bridge this connection, but still it's a universal challenge that many countries are facing. We had quite some examples then of how a personal budget system and the role of personal assistance across countries has been something invested in and tried out with some success, but still some challenges. And we had some examples of how that's playing out. But one of the major challenges then that was discussed is about how to attract people into these roles. So we recognize that this is a challenge across both the disability sector and long-term care sector. And while we had some good examples of trying to convert, for example, individuals that provide informal care into a personal assistant role or into a care worker role, there are still many challenges. And we recognized in our discussion that part of this is about having realistic program timelines to convert people into these roles, having the sufficient protections, and just trying to attract them into these roles as one way to try to ensure the availability of these types of services. So we had some really good examples in that sense. I stopped there.
Yes, well, thank you very much. I think, Adelina, we can maybe launch quickly a very, very brief questionnaire to you about how the workshop, how the workshop went and anything we can do to improve. But I think maybe we can also share once again in the chat our emails, and please do stay in touch with the network we are creating around the Global Observatory for Long-Term Care, but also that our colleagues from the European Disability Forum are creating, and we'll keep each other involved. I think we can all hopefully keep going and keep continuing this conversation. Please think of us next time you submit a project on deinstitutionalization and prevention of institutionalization. Think about involving researchers, policymakers, organizations on the ground that represent both older people and people with disabilities of all ages. And please do think about the workforce. They are at the core of everything we do, and we cannot keep forgetting about them. So it has to be that we push for true and meaningful engagement of the people who use care and support services and who need it, but also the caregivers who provide it, because all sides need support and need protection in this very complex equation going forward. Adelina, did I miss anything? Do you want to give the final word?
No, I think that was a very rich discussion. Well, congratulations on such an excellent tool. I was just thinking of how to use it in some of the projects I'm working on. So thank you so much for another great contribution and for bringing together these two worlds of disability and older people, which, the more I think we separate, the more problems we create on all sides. So it's great to come together. Thank you. Yeah, we see some comments.
I'm just very grateful to see many faces that I recognize, a lot of older and newer friends, and very glad that we are branching out and expanding a bit the network. It's not easy to break out of our own echo chambers, but I think this is an important first step. And I guess the final thank you goes to the Global Disability Fund, who has made this all possible. So thank you very much, everyone. Looking forward to seeing you next, and hope to get to work together very soon.
Thanks a lot.
Congratulations.
Thanks,
Nice afternoon. Thank you.
Bye.
Bye.
Bye.